Good morning, everyone. So I'm going to be discussing the common post-cross-linking complications that we face and try to cover most of them, hopefully. So the first topic that we'll be discussing is post-cross-linking haze. The most important thing to remember here is that not all post-cross-linking haze is a complication. It could be a normal healing response because of the increased activity of keratocytes which is seen after cross-linking, and it needs to be differentiated from the irregular haze, which is what we need to treat. This is due to irregular cross-linking because of impaired LOX and collagen dysfunction, and this is what needs to be treated. Unlike the good haze, which is paracentral and restricted to the anterior stromal area, this tends to be central and tends to affect the patient's visual acuity. So the normal cause of post-cross-linking haze is that it decreases in intensity and usually reduces over the course of 1 year. And before we assess, it's not just the visual outcomes that are impacted by this haze, it is also the topographical outcomes. So before we label a patient as progression, it is important to note if the patient has any presence of clinical haze, because that can affect your repeatability. In our studies, we found that this repeatability is least affected with the Galilei. And a more recent study has also shown that the Pentacam AXL wave is also significantly impacted by haze when it comes to repeatability measurements. Can we predict or prevent it? So this topic was extensively covered by my colleague Dr. Sneha, so I won't elaborate too much on it, but these are the factors that we need to look into in most patients. And it is important to treat the allergies, reduce eye rubbing, treat local and systemic causes of inflammation, and the post-operative protocol as detailed by my colleague Dr. Sneha is what we need to follow in most patients. The second topic that I'm going to discuss is progression. So progression is defined as an increase in the maximum K reading of more than 1 diopters over the preoperative value. And most patients of keratoconus in our studies, we've noted that they have a decreased lysyl oxidase activity, which causes impaired cross-linking. And although cross-linking tends to stabilize this to a certain extent, untreated allergies, inflammation, eye rubbing can in fact reduce this further and lead to failure of treatment. So how do we proceed in these cases? Again, it is important to treat your systemic allergies, systemic factors such as low immunity, low vitamin D, identify the factors causing progression, and most importantly, imaging needs to be performed to assess if this is true progression or pseudo-progression. So we have epithelial mapping, confocal microscopy, and collagen imaging, which can help differentiate the true progression from pseudo-progression. Another thing that can be done is assess the levels of MMP9. So what we found in our studies is the levels of MMP9 is found to be a crucial factor in progression cases and in the pathology of keratoconus. So this needs to be assessed in the tier biomarkers, and the systemic factors such as the vitamin D, vitamin B12, and IgE need to be treated. So this is a luxury that we have at our institute, that we can assess biomarker levels for various biomarkers in our own customized kit. So usually we assess the levels of MMP9 before proceeding to surgery, treat it with topical anti-inflammatories, oral supplements, or procedural dry eye therapy, and then proceed to the surgery. Repeat cross-linking, when do we do it? So if you've documented a case of failure, look at the haze before commenting on the failure. Wait for 24 to 30 months to decide if remodeling and wound healing can result in a better outcome. And if it is still progressing, rule out systemic and local inflammations, treat the causes and reassess, and then go ahead with your repeat cross-linking. The third case is that I'm going to discuss is treatment of thin corneas. So this is our 5-point management protocol that we usually follow, where cases with moderate keratoconus are treated with epi-on cross-linking or intracorneal ring segments, and advanced keratoconus with scarring is treated with penetrating keratoplasty or lamellar keratoplasty. So, but how do you treat thin corneas that have no scarring? There are various options which are currently available, but all of them have their own drawbacks. What we follow is a more customized algorithm at our institute. So there is published literature which states that the biomechanical effect of cross-linking depends more on the UV on time rather than the total UV effluence. So we derived this calculator based on a number of formulae which was fed into an online software. And we devised this calculator which is freely available for everyone to use, where we enter the thickness and it gives us the fluence time. So this animation displays what is done exactly. So you have a case of advanced keratoconus. We measure the preoperative pachymetry. After performing manual cross-linking, repeat measurement is done. We perform cross-linking with riboflavin drops given for 20 minutes. And the pachymetry, the post removal of epithelium, the pachymetry which is documented, that is what is entered into our calculator. So this gives us the UVE on time, which was 7.2 minutes for this patient, which is what we went ahead with. So we've had good results with this protocol. We've had no loss of lines and significant flattening of the keratometry values. Densitometry values showed no significant haze, and there was no significant haze noted clinically. And also it was found to be safe in terms of the endothelial cell counts. The preoperative and postoperative value did not show any significant change. We also noted presence of demarcation line in 65% of the patients at an average depth of 295 plus or minus 71 microns at 3 months post-cross-linking. And most of our patients showed good outcomes. So this is the algorithm that we follow with our patients with thin corneas at our institute. And our software is freely available for everyone to use online. So I hope this was a comprehensive enough discussion for most cases we see that post-cross-linking. Thank you.
Thank you, Dr. Sailie. Any questions from the audience for her? Sailie, will you elaborate a little on our biomarker kit, just in brief?
Yeah. So we at Narayan Nethralaya, we have our customized biomarker kit, which is customized for the analysis of 8 biomarkers. So basically, we take the patient's tears with the help of Schirmer strips. We add our patent buffer, and the resultant fluid is loaded into a cartridge, which is loaded into an immunoassay. It is basically a customized form of ELISA. And the entire process takes a period of 90 minutes. The results are delivered within 90 minutes, and the results generated can then be presented to the patient. We can quantify the biomarkers in the tears and treat the patient accordingly as per the level of biomarkers which are present in the tears.
Thank you.
Thank you.
I have a question. So
Yes.
would you be doing this for all patients?
For most of our patients preoperatively, we collect tears and we assess the levels of biomarkers. If the levels, if the inflammatory markers are raised in these patients, then the inflammation is treated preoperatively and then we go ahead with the surgery.
Right. So this is for keratoconus who require cross-linking.
This is for keratoconus who require cross-linking. This is also for our refractive surgery patients. Again, the rates of postoperative dry eye and postoperative inflammatory conditions, if a patient has subclinical inflammation and you go ahead with a LASIK, the chances of a postoperative dry eye would be significantly higher. So we tend to treat that before going ahead with the refractive procedure.
Right. So after your treatment, do you repeat the
Yes, we do a
biomarker?
repeat assessment at 1 month.
Thank you.
Dr. Sailie, so what do you suggest for clinicians who do not have access for the kit? Do we do something clinically in the OPD to see these patients, or do you recommend something else?
So obviously this is a luxury that we have at our institute. If it is not available, then your clinical assessment is what matters the most. So a comprehensive dry eye workup for every patient undergoing refractive procedures, I think, would be mandatory.
And also for keratoconus patients?
Yes, absolutely.
So just as a protocol, we should get dry workup?
Absolutely, absolutely, because these conditions tend to aggravate postoperatively, and dry eye in general is a good marker for inflammation, so it needs to be done for every patient preoperatively.
So would you give it more importance to the breakup time or the Schirmer's quantitatively to rule out these inflammatories?
I don't think that it wouldn't be just one that is more important than the other. Both of them are indicative of a different form of dry eye, so I would give both of them equal importance.
Sure. Thank you.